Okay, so I have three cases, three easy and short cases. The first one is a recurrent tumor of approximately 50-year-old female patient who has a recurrent tumor in nasal cavity, diagnosed as a papilloma, and you can see it in scanning magnification now, and I'll show you a little bit more. So it's a really papillary tumor, which is a solid papillary, let's say. There is a mucosa on the surface, and with high magnification, we can appreciate that there is a relatively bland epithelium. The tumor is composed of spindle-shaped and epithelioid cells, and you can note, you can see relatively abundant neutrophilic infiltration within the whole tumor. So what else should we discuss? Maybe this uniform growth pattern is quite typical, and even if we use high magnification, you can appreciate that the cells are relatively bland looking. Yes, so again, allow magnification to show you the structure. And so it was sent as a consult case because the pathologist really had suspicion that was recurrent tumor, first diagnosed as inverted papilloma of nasal cavity, then second recurrent tumor, had a diagnosis of papilloma with in situ carcinoma, and it was sent with the correct suspicion. And you probably already know that we did testing, and this tumor was tested and came back with a result, DEC AFF2 translocated tumor. So this is a new entity in sinonasal area, DEC AFF2 positive translocated tumor. And that the pitfall is that the tumor looks pretty bland, with no atypical mitosis. However, it's really not very bland in biological behavior, and more cases are described. We can see that this is real malignancy. So 50-year-old woman, recurrent tumor in nasal cavity, diagnosis, DEC AFF2 translocated sinonasal tumor. First case. Second case.
Our case, it is 10, no?
We have, sorry?
We have 10 cases now.
At least 10, yeah. It's more and more obvious that it's not rare, not very rare. Okay, second case is tricky.
You can tell it from the first side.
This one?
Yeah.
No.
Tubulo-papillary, yeah?
No.
No?
Excellent. So even Michal had been tricked. So this is invasive tumor of an old man. The man, it was about 80-year-old man, invasive growth pattern. The tumor infiltrated ethmoidal sinus. So again, sinonasal tumor. I'll show you higher magnification to make some kind of approximative diagnosis. Of course, that's again consult case. It was sent because the immunoprofile was not satisfying. Diagnosis of the referring pathologist was intestinal type sinonasal adenocarcinoma. However, the tumor has not been positive for CK20 and CDX2, and there even has not been CK7, so a little bit tricky for sinonasal adenocarcinoma. It's definitely high-grade malignancy, or well, some kind of malignancy with mitotic figures. Maybe I show you a little bit more of the tumor. Those are only fragments. We do not have much more. And there was a lot of immunohistochemical markers used for diagnosis. I almost ended with adenocarcinoma, not otherwise specified, but we sent it for molecular testing. And surprise, surprise, there was a translocation, which I have to read because I am not prostatic uropathologist. So that is TMPRSS2 ERK translocation, which is typical for prostate cancer.
Did you try ERK immunohistochemistry?
Yes, I
Yes,
did. I did. It was nice. After this translocation arrived, I did androgen receptors positive, prostatic specific antigen positive, NKX3.1 also positive, but it was not tried during the work up at the primary place, and also so very pitfall, something like pitfall. Yeah, so that's my diagnosis, and this was it was helpful to have molecular testing in this case. So diagnosis is metastasis of prostatic carcinoma in old men, and metastasis arrived into the sinonasal tract, mimicking primary sinonasal adenocarcinoma intestinal type. And finally, I have something also quite nice, and that is thanks to Zdeněk Kinkor, who was so nice to pass this consult case to me, and I was really angry first time because when I saw this tumor, I said, well, so it's a difficult case. It's a tumor of parotid gland. I don't know if you can see it sharp enough. I'll use high magnification immediately. So tumor of parotid gland in 10-year-old girl. The tumor was relatively large, somehow multinodular, very pinkish, nodules divided by such fibrous hyalinized septa. Most of the tumor actually most of the tumor tissue was composed of solid mass, almost completely formed by oncocytes. Only minor component was something like this with tubular structures. So most of the tumor was just oncocytoma, something. But these structures, which you can see at this moment, made me to decide to ask for a molecular testing, and the result came with expected results. So it's actually oncocytic variant of Mucoepidermoid carcinoma. The result was CRTC1 mammilla2 fusion in this tumor. So it may be really very, very tricky. And when you see the tumor like this, you always, in parotid gland, you always should think about two possibilities, that it's not oncocytoma or oncocytic carcinoma. It can be either oncocytic variant of mucoepidermoid carcinoma or even oncocytic variant of myoepithelioma or pleomorphic adenoma. This case was negative for PLAC1, negative for HMGA2, and was positive for P63 in full tumor. And when you have this diagnosis with CRTC1 mammilla2, it's easy to see that at least in some places there is not mucose cells, mucinous cells, but some kind of mucin production. which is almost invisible on hematoxylin eosin stained. So this is what you can see finally, but not really intermediate cells or typical mucinous cells. So can be quite difficult to make diagnosis of fully oncocytic variant of mucoepidermoid carcinoma. So finally, the diagnosis is oncocytic variant of low-grade mucoepidermoid carcinoma in young girl. So that's all from my side.
Tak Rude.
Hello everyone, Marián Švajdler here. All the best in the new year. And I've got a couple of cases. This is from our colleague Jožo, and this is a case of it's a middle-aged male patient with abdominal mass, solid and cystic by CT scans, and next to pancreas and aorta, and they performed this fine needle biopsy with some fibrous tissue here and some hyaline cartilage tissue, and in addition you can see some glandular structures here and here. Okay, so when Jožo showed me the case, I asked him about the clinical history of the patient, and the patient has got a history of germ cell tumor, right? So we were not quite sure whether these are normal structures. Probably some of these epithelial cells are normal. It's some kind of small intestinal mucosa. But in addition, these other glandular structures, you cannot really tell what it is. And you've got this hyaline cartilage here. So we performed molecular genetics, and we proved that there is amplification of 12p chromosome. So this is germ cell tumor with morphology of teratoma, and it's metastatic germ cell tumor. Okay, so this is how when you are not sure whether you are dealing with mature tissues, normal ones, or metastatic germ cell tumor, you can use molecular genetics. Clinically, it's a problem because it's well-differentiated tissue which will not respond to chemotherapy, and in fact, the so-called syndrome of growing teratoma is very difficult to treat, and many patients will die because of they have this growing teratoma somewhere in important region of the body. Okay, I've got maybe 2 or 3 brain cases. This is just I already showed here some examples of this tumor. This is younger lady with brain tumor, and this is already recurrence of the tumor. And this is just to show you beauty of neuropathology, and these beautiful, bizarre, giant neoplastic cells. You will not see so bizarre cells in any other organ system. These bizarre shapes and multinucleated and really huge cells are very typical of giant cell glioblastoma. Okay, these tumors are typically IDH wild type and show typical genetic profile of IDH wild type glioblastoma. So the prognosis is very bad. Clinically, it may manifest as quite well circumscribed mass, which quite frequently is described as possible glioma, but in fact it's always infiltrative, and the prognosis is very bad, similar to classical glioblastomas. Okay, another. This is very young lady with the brain tumor. So in this low magnification, you can tell it's probably glioma, diffusely infiltrating with some spindle cells. This looks like classical diffuse infiltrating astrocytoma. But in other parts, you can see this more brown cell morphology, like here. And maybe even a little bit of Oligodendroglioma-like morphology with perinuclear halos. So in the days before molecular classification, we probably would call these oligoastrocytomas, but this is not relevant with very few exceptions today. Importantly, the tumor was negative for IDH1 by immunohistochemistry, so this was not helpful. And tumor had retained expression of ATRX protein, so if there is a loss of expression, it's probably astrocytic tumor, but retained expression does not tell you nothing. And we have performed molecular genetics, and the tumor showed very rare IDH2 gene mutation together with 1P and 19Q co-deletion, so it's oligodendroglioma, IDH mutant and 1P, 19Q co-deleted, so with very rare IDH2 mutation instead of very typical IDH1 mutation. Okay. I've got another case. This is 3-year-old girl with thalamic tumor, very small biopsy because it's deep-seated structure. And in low magnification, you can see quite low-grade morphology. There are some mitotic figures, but you have really carefully search for them. It's a really low-grade appearance with no microvascular proliferation, no necrosis, very blunt-looking cells, and very few mitotic figures, but it's in the midline, so we have performed two immunochemical stains. The first one is histone H3, K27M, and it's diffusely positive. So it shows you that the mutation in H3 histone gene is present. And in addition, you can see this histone H3 K27M 3 methylated form loss of expression. There is internal control, you should always have that, with background glia and some endothelial cells, maybe some inflammatory cells are positive, but there is loss of expression of neoplastic cells. So this is midline, diffuse midline glioma H3 altered according to WHO 2021 classification. Because the morphology is so low grade and the diagnosis is very important because it's very aggressive tumor, not treatable by current means, and expected survival is less than 1 year. We have performed methylation profiling and genetic testing, and H3 mutation was present by molecular studies, and glioma was classified as midline glioma by methylation profiling. So very bad prognosis, but there are some studies ongoing with maybe some positive results, but right now it's not treatable. Another case, this is fine needle aspiration biopsy from cystic and solid mass in the pancreas. can see this blood clot and some cells in there. So this is easy one. Any suggestions here? So the cells are roundish, with a little bit eccentrically displaced nuclei. Not really salt and pepper chromatin, but if you perform immunohistochemistry, you can make a diagnosis. But of course, there is differential diagnosis of solid pseudopapillary and well-differentiated neuroendocrine tumor. Okay, so this is synaptophysin staining. It's diffusely positive, but synaptophysin is not enough because solid pseudopapillary as well as NET may show synaptophysin positivity, so you have to perform your chromogranin staining, and chromogranin is diffusely positive in addition to INSM1 nuclear, so it's well-differentiated neuroendocrine tumor. Always perform chromogranin in addition to synaptophysin. In addition, beta-catenin was negative in this tumor, which would be positive in solid pseudopapillary neoplasm of pancreas. And this is I67 or MIB1 staining, which shows maybe few cells positive, but most of the tumor cells are negative. So can you do the grading from this fine needle aspiration biopsy or cytology material? Of course you can do with some caution, but I graded this tumor as grade 1 because the proliferative activity is almost 0 and no mitotic figures were found. So you should attempt always grading even in small biopsies and cytology specimens. Okay, another case. This is fine needle aspiration biopsy from a neck mass. So this is head and neck pathology. You can see some bluish cells with high nucleocytoplasmic ratio, really ugly looking cells. Okay, so cytokeratins were positive in these cells, and Ki67. I will show you Ki67. Okay. Sorry. Almost all cells are positive, so it must be really bad tumor. Okay. P16, as suggested, is diffusely positive. Okay, so it still could be either small cell carcinoma because almost 100% of small cell carcinomas are P16 positive. Okay, so you should not rely on P16 staining, but I have performed P40 staining and the tumor cells are all are positive. So this must be squamous cell differentiated with P16 positivity, but we are in a metastatic setting. So we have to perform molecular testing for HPV, and it came back as positive. So this is probably a metastasis of P16 HPV-associated oropharyngeal carcinoma. So they should look at the tonsils and oropharyngeal sites. And clinically, if they cannot find anything, they should make sampling of the sites or even perform tonsillectomy to prove that it's the origin of the tumor. Another cytology case. This is ascites in a older lady. And from this you can tell it's not benign. Okay, we've got hyperchromatic nuclei. It's not very well preserved, so I always, in these cases, I perform Claudin-4 and MOC31 staining. It came back as positive. So with Claudin-4 and MOC31, you can confirm that you are looking at the epithelial malignancy inside the abdominal cavity. Claudin-4 is probably the best screening marker. With exception, nothing else except for epithelial malignancies is positive for Claudin-4. So it's lady, you should go with your PAX-8 staining, and it's positive. It's not very good working in our hands, in our lab, but I still believe it's nicely positive. And WT1 was positive. Okay, this is very nice, even in cytology. And you should try P53 staining, and you already have a diagnosis, right? I always, in addition to this, I always perform Ki67 staining. Almost all cells were positive in this specimen, so you can tell them it's high-grade serous carcinoma, probably of tubo-ovarian origin. Done. This is a nice case. It's again quite old man with lung tumor, mediastinal tumor, multiple foci on pleura, and they perform this core needle biopsy, and it's this epitheliate, almost solid proliferation. The cells are quite atypical looking with prominent nucleoli. This is what I want to see in this tumor type. Okay, so any suggestions? So we should differentiate it whether it's epithelial or mesothelial in origin, and this is coloretinine staining. When it's properly done, you should have this strong cytoplasmic and nuclear staining. It's not always the case at least in our lab, but in this case it's quite nicely positive in the nucleus and cytoplasm as well. And D240 was positive, WT1 was negative. So you should always perform several mesothelial markers, not only one, because one or two may be negative and the third one is positive. And this is BAP1 staining. We know that approximately 1/2 of mesotheliomas have BAP1 mutation and loss of BAP1 expression. The antibody is quite tricky, probably dependent on fixation, but you can see that non-neoplastic inflammatory cells have retained nuclear expression, and there is loss of expression of BAP1 in tumor cell nuclei. And in addition, we have performed MTAP staining, which is marker associated with CDKN2 locus loss in mesotheliomas. Again, you've got this retained expression in non-neoplastic stromal cells and loss of expression of MTAP in tumor cells, indicating there is a loss of CDK and locus in the genome. So the diagnosis is epitheliate mesothelioma. Malignant, yeah. Even when you are doing diagnosis of mesothelioma, you should have clear infiltration into non-neoplastic tissue to be 100% sure. But with these immunohistochemical markers used instead of molecular genetics, positive results, you can tell it's mesothelioma even without having infiltration into non-neoplastic tissue. So another case, this is a young patient with a skin nodule, sent in consultation just to confirm the diagnosis, and it's easy and quite frequent tumor type. So from this low magnification, you can see something what can be called storiform growth pattern, very prototypical with short fascicles intersecting each other. So the morphology is not really high grade, but this is very interesting to have these fat cells, adipocytes, within the lesion. And when you go to the periphery, you can see this typical honeycomb-like infiltration into the subcutaneous fat. And the lesion was immunohistochemically positive for CD34. And because it's a consult case, I have performed molecular genetics just to confirm that it's Dermatofibrosarcoma protuberans, and it came back with the prototypical COL1A1 PDGFB fusion. So it's very typical example of Dermatofibrosarcoma protuberans without so-called fibrosarcomatous transformation. Another consult case, this is 12-year-old girl with retroperitoneal mass. And it's this spindle cell lesion. I already found the very diagnostic focus here. So if you look at the spindle cell component with this very blunt looking wavy nuclei, it looks like schwannoma. And in addition, you've got these plump, big ganglion cells, and the diagnosis is ganglioneuroma. If possible, you should examine the whole tissue, submit all tissue, because you have to rule out this less differentiated component of neuroblastoma, because although ganglioneuroma is considered to be a benign lesion, by most authors, it is considered to be the most benign part of the spectrum of neuroplastic tumors, starting with undifferentiated neuroblastoma and ending with this well-differentiated ganglioneuroma. And sometimes there is a category of mixed tumor with this ganglioneuromatous component, well-differentiated, and nodule of less differentiated neuroplastic component. So you have to search for it and describe it and grade it according to International Neuroblastoma Study Group. Okay.
Which is a horrible job.
Yeah, it's a horrible job because you have to count mitotic figures and apoptotic bodies and
Whole day work.
yeah.
I'm glad we don't get this.
And this is quite a nice case. Unfortunately, it was sent. They already just before the case arrived, they told me that they had some technical issues that day, so the tissue is not technically very good. But again, we are at head and neck, and this is submandibular salivary gland here. Okay. Here, with some neoplasm here. So this small round blue cell with nested and solid architecture. I'm sorry for that, but really the slide is ugly. Okay. And this is very high magnification. You can see roundish nuclei with, I would say, salt and pepper chromatin. Not many mitotic figures were found. I will show you proliferative activity if you are interested. So this is Ki67 staining. It's quite prominent, but not that high. So I performed several stainings in addition to what they performed, and the most relevant staining is this. It's INSM1 staining, so with nuclear positivity.
So it's probably metastatic.
And this is synaptophysin positivity here, with very weak chromogranin positivity, so we deal with neuroendocrine tumor. According to this proliferative activity, it's something between grade 2 and grade 3. And as just Alena said, in salivary gland, we have primary salivary gland neuroendocrine tumors, but
rare.
these are exceptionally rare tumors, and you should always, or clinicians should always rule out possibility of metastatic, well-differentiated neuroendocrine tumor into the salivary gland. And if they found nothing, there is possibility to have primary, well-differentiated neuroendocrine tumor of salivary gland. Regarding the grading of the tumor, this is probably grade 3 tumor, but the grading scheme is a little bit different in the head and neck area, in sinonasal and salivary gland tumors. You should go to WHO book. So it's similar to, let's say, pancreatic or gastrointestinal, but a little bit different. The cut-offs and definitions are a little bit shifted from GIT. Okay, so that's from my side.
Hey, good afternoon, everyone. It's Michael Jr. here. So this first case, that was some 20-year-old lady, or a lady in her 20s, with a inguinal soft tissue tumor, which I'll use this magnification on low power. You can appreciate there's adipocytic differentiation. And also it's multilobular. It's separated into lobules with these fibrous septae. In other slides, it may look more convincing. So multilobular tumor with adipocytic differentiation. When you go on higher power, it's composed of these bland ovoid to spindle cells and myxoid stroma with, again, obvious adipocytic differentiation, which on higher power create very often these very textbook-like lipoblasts. So in this age group, there are basically three possibilities with this morphology, what this could be. Definitely, you should rule out myxoid liposarcoma, because it's a lady in her 20s, so it's a typical age group for myxoid liposarcoma. However, we did DDIT3 immunohistochemistry, which is basically 100% sensitive for these tumors, and it was completely negative. Another possibility, which is the least likely, is lipoblastoma, which basically looks identical like this, but these tumors are caused by PLUG1 gene fusions. So you very often or almost always have PLUG1 immunohistochemical positivity as well, which was not the case here. PLUG1 was negative. And so the third possibility when you exclude these two diagnoses is a tumor which used to be called Lipoblastoma-like tumor of the vulva, because it was thought to arise exclusively on the vulva. Today, we should better call it Lipoblastoma-like tumor, because there are very, very well documented cases of extravulvar cases, which can arise basically anywhere in superficial soft tissues. So not in retroperitoneum or mediastinum, but in any superficial soft tissue site. But still, like over 90% of cases are in the vulva or inguinal area of women, but there are cases in men outside of anogenital region first case. Second case, there was an old patient, old guy, who was diagnosed a few weeks before this biopsy. He was diagnosed with some duodenal polyp, where was high-grade dysplasia, and it was impossible to comment on possible invasion. But in any case, the polyp caused obstruction, so he has lost 15 kilograms of weight in recent months. And I guess the clinicians saw some enlarged lymph nodes in the retroperitoneum, and because there was a high-grade dysplastic polyp without the possibility to exclude invasive carcinoma, they sampled the lymph node, and this is what we received. So basically normal lymph node with some reactive changes, and around the lymph node you see this weird fatty tissue, which again in many areas creates perfect lipoblasts. So you may start to think of some adipocytic tumors. But the key information here is that the patient has lost 15 kilograms in recent months. So this is basically a fat atrophy. So this is atrophic fat. We have few more cases like this. Always there is a history of some large operation, some tumor, some oncological diagnosis. So this is really, if you know about it, if you remember this, it's easy to diagnose. You can see how it's still lobular, very well organized like normal fat tissue. It's just smaller, atrophic, and as the fat vacuole kind of shrinks, the nuclei become more prominent. So that was the second case, fat atrophy. The next case was a 20-year-old boy with a tumor on his buttock. The skin lesion. We got this skin biopsy, kind of polypoid in shape. And you can see the epidermis is completely unremarkable, but in the dermis there's something. There's some tumor, which looks quite dark on low power, and on higher power you can see it's basically very uniform ovoid to round cells with some inflammation here, which makes it a bit more difficult to diagnose, but the main proliferation are uniform ovoid to round cells with some mitotic activity. So you do some basic immunohistochemical panels, S100, SOX10, Desmin, and so on. Everything was negative. And because it's a basically round cell neoplasm, you should not forget round cell sarcomas. So this is CD99, which is basically completely useless stain apart from one diagnosis, and that's Ewing sarcoma. And the only expression you can use is this one, basically diffuse strong membranous positivity, which is very sensitive for this tumor. It's not specific, it doesn't make the diagnosis, but it kind of, it's a good screening marker basically. Then you can use NKX22 if you have it at hand, which is a nuclear marker, again very sensitive, not entirely specific, but here's diffuse NKX22 expression. And another marker for Ewing sarcoma is PAX7, PAX7, which is a very good marker of skeletal muscle differentiation, but for some reason it's also overexpressed in Ewing sarcoma. So again, diffuse nuclear positivity. So this is very likely to be Ewing sarcoma even without genetics. We also tested the genetics, and there was a EWSR1 ERK fusion, so a typical fusion for Ewing sarcoma, which is a very aggressive tumor if it's in bones. It's aggressive tumor if it's in deep soft tissues, but if it's superficial like this in the skin, it usually has very good prognosis if it's caught early. Okay, so this is actually the case I'm going to show now. This is the reason why I showed the previous one, the Ewing sarcoma of the skin. This case came at the same period, funnily enough, as we received the Ewing sarcoma. So this is next case. It was a 70-year-old lady with a perianal polypoid lesion, which was measuring some 2 centimeters. And we had some real troubles with this case here. It took us over a month to diagnose it because we had some problems with molecular testing. So this is the lesion. So this traumatized polypoid skin lesion, you can see the rest of epidermis here. And in the dermis, you see again something very ugly looking, even from this, low power. So very dark, very cellular, in this multiple nodules, arranged in nodules. And if you look on higher power, again, you see very uniform, perfectly round cells, quite prominent mitotic activity. So again, you obviously think now of Ewing sarcoma or some round cell sarcomas. But still you have to do your basic panel, basic mesenchymal panel. So S100 protein, which we did. S100 protein is diffusely strongly positive in 100% of cells. You can do also desmin as part of the basic panel. It was negative. With this much S100, it's always good to add SOX10. SOX10 is positive again in every cell. Basically, every one of the normal or routine markers, basic markers, was negative. So we added C99, which in this case was completely negative, which would be not impossible for Ewing sarcoma, but very unlikely. And we did molecular testing, which was negative for every mutation. Methylation analysis didn't find anything. And unfortunately, the most important RNA analysis didn't work. Because it took us so long, we already thought that we have to diagnose it somehow. So we said that probably it's a melanoma. It's an old patient. There was some UV signature in it. So it's probably melanoma. But eventually I decided to add one more RNA sequencing. And eventually we got EWSR1 Fly1 fusion, which is the typical fusion of Ewing sarcoma. Well, the trick is it's probably most likely not Ewing sarcoma because we have this diffuse SOX10 and diffuse S100 protein expression, and we have now a new entity described by Andrew Falb, which is called superficial neurocrystic FET-ETS, which means EWSR1 or FUS fusion with the typical Ewing sarcoma partner, so Fly1 or ERK fusion tumor. This is already second paper on this topic. The other one was like 2 months ago. And exactly these tumors are always superficial. They always look like, they are always round cell in morphology. They resemble kind of like Ewing sarcoma or epithelioschwannoma. Always this multilobular, multinodular arrangement. Always diffusely SOX10 and S100 protein positive. This paper already showed for the first time that there can be quite remarkable mitotic activity, up to 10 mitoses. So the first paper said that basically non-mitotically active tumor, but this paper with more cases proved there can be a lot of mitoses as well. It often is CD99 positive, NKX22 positive as well, not in our case, but most cases are. Here is one of their cases. Basically, it looks identical to what we have here. Very often polypoid, small cutaneous superficial lesion composed of these small cell nests. And what is interesting, because the immunophenotype S100 SOX10 points towards like a neuronal differentiation. This is a methylation analysis plot, kind of showing you the methylation profiles. This is a methylation profile of like 20 cases of Ewing sarcoma. Here you have like alveolar soft part sarcoma, some other entities in soft tissue pathology. And here is methylation pattern of neurofibroma. And this is the tumor we are talking about, neurocrystic Ewing-like tumor. So it's very close to conventional neurofibroma and to schwannoma. So really most likely some neuronal tumor, which happens to have the same translocation and very similar morphology to Ewing sarcoma. The important thing is that all, I think 15 cases that have been reported so far were completely benign. So although Ewing sarcoma in superficial skin sites has very good prognosis, still there are like 10% of cases which can present with widespread disease and the patient needs chemotherapy. but this case so far has been always benign. So this is a very tricky diagnosis. Always do S100 SOX10 to make things more complicated. There are cases of pure or real Ewing sarcomas which can be S100 and SOX10 positive, but they are usually not as diffused. It's like just few cells or patchy positivity, not 100% cells as here.
I think you need a longer follow-up.
Yeah, we of course, it's a new entity. We might learn to know that eventually this tumor is as aggressive as normal Ewing sarcoma.
So what was the clue to diagnosis?
S100,
Testing.
SOX10 positivity, diffuse, and the fusion. Without the fusion, it's
Yes.
impossible to do it. I think last two cases. This was a 40-year-old guy with some ulcerative duodenal lesion, and on CT scan, I think he was said to have some big retroperitoneal or intra-abdominal tumor. And we got first this little biopsy where you can see some remnants of the duodenal mucosa and some spindle cell proliferation here. There is a lot of inflammatory cells, but still in the background you can see there's a lot of hyperchromatic spindle cells. So it came to me with like most immunos done, DOG1 was negative, all the GIST markers were negative, smooth muscle markers were negative. And if you look closely, you can see like hyperchromatic spindle cells, but what is also important, you can see that they have very remarkable differences in size and shape. So you have this big plump, ugly hyperchromatic spindle cell, as well as this longer one, and very narrow, thin one, which is also hyperchromatic. So this is like a clue for me that this could be some sarcoma with complex karyotype. So they have very big differences in the tumor cells. They are not uniform. And because we are in this location, the number one option is dedifferentiated liposarcoma. And indeed, if you do MDM2, you can even better now appreciate the large variability in the size and shape of the tumor cells. So this was, very small sample. So you can basically say this is most likely, this can be most likely dedifferentiated liposarcoma. It's hard to say 100%, but in 1 or 2 weeks we received resection from this patient. It was a giant retroperitoneal tumor. You can see this is close to pancreas, also infiltrated kidneys, and the morphology here. And here it's very easy to make the diagnosis. So this is indeed dedifferentiated liposarcoma in these parts without adipocytic differentiation completely. So the variability in hyperchromatic, variability in size and shape, and hyperchromatism of the tumor cells, that's the key along with MDM2. So I think we are out of time. So thank you for your attention, and Happy New Year.
Happy New Year.